An infant presents with multiple fractures and blue sclerae. I'm showing you the babygram. Describe the findings.
Okay, I see it. The babygram demonstrates generalized severe osteopenia with marked thinning of the bony cortices. There are multiple fractures of differing ages affecting the metaphyses and diaphyses of the long bones. These fractures are associated with bowing deformities and exuberant hyperplastic callus formation. The primary diagnosis is osteogenesis imperfecta. The main differential diagnosis for multiple fractures of varying ages is non-accidental injury.
How would you differentiate osteogenesis imperfecta from non-accidental injury, and what is the underlying pathophysiology of this condition?
In that case, differentiating the two can sometimes be difficult, but fractures in osteogenesis imperfecta are predominantly diaphyseal, whereas non-accidental injury typically presents with metaphyseal corner fractures and posterior rib fractures. Furthermore, the generalized osteopenia and severely thin cortices seen here are characteristic of osteogenesis imperfecta, not non-accidental injury. Pathophysiologically, osteogenesis imperfecta is a congenital connective tissue disorder caused by mutations in the genes encoding type 1 collagen. This leads to structurally abnormal collagen synthesis, compromising the integrity of the osteoid and resulting in severe bone fragility.
I am now showing you a lateral skull radiograph of this patient. Describe what you see and name some other conditions that can cause this.
Well, as seen in this lateral skull radiograph, there is marked thinning of the calvaria. Most notably, there are multiple intrasutural accessory bones, known as wormian bones, lining the sutures. This is a classic cranial feature of osteogenesis imperfecta. The differential diagnosis for wormian bones includes pycnodysaustosis, healing rickets, cleidocranial dysostosis, hypothyroidism, and Down syndrome. However, in the context of the diaphyseal fractures and osteopenia we saw earlier, osteogenesis imperfecta is the definitive diagnosis.
What are the clinical subtypes of osteogenesis imperfecta, and what other skeletal features might you see in the spine?
Okay, osteogenesis imperfecta presents in several types. Type 1 is compatible with life, while Type 2 is the lethal perinatal form. Aside from the limbs and skull, the spine can also be severely affected. The soft vertebral bodies can be compressed by the nucleus pulposus, resulting in biconcave or codfish vertebrae.
How would you manage this patient as a radiologist?
As a radiologist, I would document all fractures and compare these films with any prior skeletal surveys to track fracture healing. I would monitor for complications such as basilar invagination on lateral skull or cervical spine views. I would communicate these findings urgently, ensuring that non-accidental injury has been formally ruled out clinically. Finally, I would refer the patient for multidisciplinary care involving pediatrics and orthopedics for medical intervention and potential surgical correction of bowing deformities.